Hello. Hi there. Good morning, good afternoon. Hello, everybody. Welcome to this final presentation before the end of summer. Improving access to mental health services for newcomers, children, and their families, insights from a citizen panel and stakeholder dialogue. And before we begin this presentation, we would also like to begin with an acknowledgement that N4 is hosted at CHEO, which is located in Ottawa, Ontario. Ottawa is built on unceded Algonquin and Anishinaabe territory, and the peoples of the Algonquin and Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. Their culture and presence have nurtured and continue to nurture this land. We also honor all First Nations, Inuit, and Métis peoples, and their valuable past and present contributions to this land as well. Excuse me. My name is Andrew Tomeyer. I'm N4's Education Coordinator. I'll be hosting and moderating today's presentation. With me today is my colleague and co-host Colleen Drake, who is N4's Project Coordinator, who will be monitoring our Q&A box today. And now I'm pleased to introduce you to today's presenters. First, we have Ahmed Ali, Scientific Lead for the Equity-Driven Evidence Support and Editor of Health Systems Evidence at McMaster Health Forum since January 2023. He has a PhD in health policy from McMaster and develops many pieces related to health equity, social determinants of health, key policies and procedures to help improve our healthcare system. Amanda Sim is assistant professor in the Department of Psychiatry and Behavioral Neurosciences at Global Health graduate program at McMaster. She has a PhD from Oxford in evidence-based social intervention and conducts community-engaged research to promote newcomer mental health and well-being. And finally, we have Kaylin Moat, the Managing Director and Senior Scientific Lead of Evidence Products and Processes at the McMaster Health Forum. He's also part-time assistant professor at McMaster. He has a PhD in health policy as well, and much of his recent research and work relates to strengthening evidence support systems domestically and globally. Welcome, everybody. Today's session is being recorded and will be uploaded to N4's platform within the next week or so, and we will share this with you attendees as soon as it becomes available. Should there be any technical issues during this presentation at all, we'll inform you with details for any possible alternate makeup session, if that so may happen. And before we begin today's event as well, we'd like to just show you where our Q&A piece is so that you can provide your questions in the Q&A window. We know many times many of you might have the same question or be interested in a particular response. There is the option to upvote questions. So please upvote questions you're interested in hearing the answer to as well within our Q&A portion of the presentation, and we'll pose them to our speakers. N4 is pleased to announce that today's webinar is accredited. Members of the Royal College of Physicians and Surgeons of Canada, as well as those that are part of the Canadian Psychological Association, can earn credits towards maintenance of their certification requirements by attending today's webinar. Members will receive 1 credit for attending this webinar today. And our presenters do not have any conflicts of interest to declare. So with that said, I will pass it right over to our wonderful presenters. Take it away.
Great. Thank you so much, Andrew, and to N4 for hosting us today. My name is Amanda Sim. I am one of the PIs on this study. My co-PI and colleague, Dr. Andrea Gonzalez, sends her regrets that she can't join us today. Before I hand it over to Kaylin and Ahmed from the McMaster Health Forum to talk more about this work, I wanted to first just give everyone a bit of context and background around why Andrea and I decided to initiate this project. Both of us work in the parenting and mental health space. And we've been working over the last number of years on trying to understand and address the disparities that we've seen that has been documented around access to mental health and parenting support for equity-deserving groups, in particular refugee, immigrant, and racialized populations. Now, these disparities are not new. We know from the Ontario Child Health Study from 2014, this is a population-based survey that was done across the province. We know from that work that in general, there's a high prevalence of child and youth mental health problems in the general population, somewhere around 18 to 20%, with a large treatment gap, but that refugees and immigrants and racialized children and youth are even less likely to receive care. So for example, refugee and immigrants are 40 to 50% less likely to receive care compared to their non-immigrant peers, even after you control for level of mental health symptoms. So as Andrea and I were doing this work in the communities, primarily around the GTA area, we were also coming across this realization that there are much larger systemic and structural issues at play that are hindering our efforts to promote equitable access to mental health and parenting support for this population. And one of those larger systemic issues is the lack of a national framework to guide provision of care for this population. Now, there's certainly been previous work and advocacy around this issue, stemming from 2008, for example, when the Mental Health Commission of Canada established a diversity task group to examine mental health service provision for immigrant, refugee, and racialized groups in Canada. And these reports, really highlight the need for a national dialogue, a national framework to coordinate a more effective and equitable response. However, these reports and recommendations did not focus specifically on the needs of refugee and immigrant children and youth, and are also pre-COVID. And as we all know, the COVID-19 pandemic has really changed the context in terms of mental health need and also mental health service provision and treatment gaps. And there have also been other contextual shifts. For example, changing demographics of refugees and immigrants coming to Canada, as well as growing awareness of systemic racial and ethnic discrimination. So given all of this, our goal through this work, which is funded by CIHR, a Catalyst grant from CIHR, our goal was to leverage findings from our own work as well as the work of many others and integrate evidence with input from key stakeholder groups, including refugee and immigrants themselves, service providers, and policymakers. And our vision is to co-develop a national child and youth mental health framework to promote equitable service provision and access to care for immigrant and refugee children, youth, and families. So we've been really fortunate to partner with McMaster Health Forum to conduct this work. And I'm really pleased to hand it over now to Kaylin and Ahmed, who will tell us more about the approach that we took and some findings from our work so far. Thank you.
Fantastic. Thanks, Amanda. So I'm going to speak very briefly on the McMaster Health Forum's approaches more generally, and then I'm going to hand it over to Ahmed, my colleague, who's going to really dive into the meat of what we did for this project, some of the key insights coming out of it, and some of the next steps that were shared by citizens and stakeholders for this topic. And then Amanda will take us home at the end before we open up for questions. So Ahmed, if you could advance the slide there, what you'll see in front of you really is just our way of trying to describe the type of work that the McMaster Health Forum does. So Amanda and Andrea would have kind of heard about us through across campus as one of the groups who often engages with folks at the university who are really looking to engage citizens and stakeholders to have evidence-informed deliberations about priority policy topics. And I think Amanda set us up really nicely to understand why this particular issue is a priority. So the forum really tries to champion change through a number of different ways. And we often describe ourselves these days as focusing on strengthening evidence support systems. So there's the research system, those out there doing studies, syntheses that are trying to answer particularly pressing questions of the day. But then there's this other system that we're now talking about where timely demand-driven supports to decision makers are required to try and leverage stuff that's already been done, as Amanda mentioned, as well as hot off the press evidence that may be relevant to particular priority policy decisions. So we do this in a number of different ways. So we have under our Learn How bucket, things like courses and webinars and public events to try and support the development of the skills and competencies required to do evidence support well. We also run a number of programs which we group under Find Global Evidence. So this is where we do evidence products, which in some cases look like many of you will have seen systematic reviews. We do those types of things. And we also develop and maintain two of the world's best-in-class databases of pre-appraised synthesized research evidence about health systems, social systems, and optimal aging. We also have a bucket called Find Domestic Evidence. So this is where I speak to that really targeted, timely, demand-driven work where we'll receive a request from a decision maker, say in the Ministry of Health, bring our team together and rapidly answer a question, sometimes in hours, but most often in days and weeks, using best evidence and insights from jurisdictions to try and answer a question based on what we already have in terms of the research evidence and pull it together in a way that makes sense to answer those questions. Spark Action is where today's presentation will focus. So Amanda and Andrea engaged us because we do have a lot of experience. I think we're nearing 80 now stakeholder dialogues, more than 100 citizen panels that often feed into stakeholder dialogues. So key decision makers can get insights about priority issues from citizens as well. And we also engage in communities of practice in all the areas that I've already mentioned. We also function as the secretariat and technical support for a number of different networks, both I would say locally, and what I mean by locally in my context is in Ontario, where we sit at McMaster through the Rapid Improvement Support and Exchange, or RISE. During the COVID-19 pandemic, we had a network that we helped to shepherd this timely demand-driven responses to decision makers using best evidence in the COVID network. And then more recently, and this is as a follow-up to the COVID network, we established the Global Commission on Evidence to address societal challenges, and we serve as a secretariat for that. So I'll stop there. I'm going to hand it over to Ahmed, but really just wanted to provide everyone on the call with a little bit of context as to what the McMaster Health Forum's approach is to supporting evidence-informed decision-making. But Ahmed's going to really dig into things that relate mostly to Amanda's helpful framing at the end. So over to you, Ahmed. Thanks, everyone.
Great. Good afternoon, everyone. I'm Dr. Aminur Ali. So today I'm going to be presenting our work on improving access to mental health services for immigrant, refugee, and asylum seeker children, youth, and their families in Canada. I'll walk you through our process, share what we found, and offer a few thoughts on where to go from here. But first, I wanted to acknowledge the support and collaboration that made this work possible. As mentioned earlier, this project was funded by a CIHR Catalyst grant, and we've been fortunate to work with Drs. Andrea Gonzalez and Dr. Amanda Sim, whose expertise and commitment have been invaluable. We'd also like to thank our citizen panelists and stakeholders. Your insights have shaped every aspect of this work. At the McMaster Health Forum, we're dedicated to using the best available evidence to tackle the most pressing issues in health policy and social policy. With this project, it shows what's possible with research when research, lived experience, and policy come together. So let's set the stage. Canada's immigrant and refugee population is growing rapidly. The government aims to welcome 500,000 newcomers each year by 2025, including more refugees. But behind these numbers are real people, families, children, facing serious mental health challenges and barriers to care. For many, mental health needs arise from the complex interplay of pre-migration trauma, the stress of resettlement, and the everyday challenges of adapting to a new culture. They often encounter a mental health system that, despite its strength, isn't fully equipped to address the nuances of their experiences. The stakes are high. Rising mental health issues, long wait times, underfunded services, workforce shortages, and structural barriers all stand in the way of accessible care for newcomers. The good news, we have an opportunity and a responsibility to address these challenges head on. It's not just about filling gaps, but rethinking how we deliver our care in ways that meet people where they are. At the forum, our approach is all about connecting the dots between evidence, lived experience, and stakeholder insights. We start by identifying the needs of policymakers and stakeholders, then gather input from partners, steering committees, and key informants. From there, we dive into evidence briefs, convene panels, and host dialogues, all with the goal of generating actionable insights. For this project, we prepared a citizen brief that outlined the challenges and potential solutions, grounded in the best available evidence. We then held a citizen panel with 14 participants, providing a platform for newcomers to share their stories, and convened a stakeholder dialogue with 16 leaders across the health system. Our goal was to explore the challenges, discuss potential solutions, and identified the barriers and opportunities for improving mental health services for newcomer families. Now, this wasn't just a meeting of minds, it was a collaborative effort to build a path forward based on evidence and experience. So let's talk about what we heard from the citizen panel. As I mentioned, we brought together 14 individuals from across Canada, all with diverse backgrounds and lived experiences. They painted a clear picture of the problem. Adapting to life in Canada is tough, and mental health issues don't just affect individuals. They ripple through entire families. Parents' mental health struggles often impact their children, and support systems are limited. Participants described how language barriers, unfamiliarity with the health care system, and a lack of culturally sensitive care create significant obstacles. This just wasn't about access. It's about feeling understood and supported in a way that resonates. They talked about the frustration of long wait times, the difficulty in finding care that considers their cultural context, and the emotional toll of feeling isolated. These are not abstract issues. They're tangible problems affecting real people every day. What struck us most was the sense that mental health is often left out of the equation when it comes to resettlement support, despite being a critical factor in successful integration. From there, from the panel, 3 key elements emerged for improving mental health services for newcomers. First, there is a need to develop a tailored framework that starts with proactive outreach, engaging newcomers through trusted professionals and community organizations. It was about opening the door early and keeping it open with regular assessments that track not just the symptoms, but the broader context of their lives. The panel emphasized the importance of trusted community figures, so like religious leaders, school counselors, or settlement workers, who can help bridge the gap between mental health professionals and newcomer communities. These figures often serve as the first point of contact and can play a crucial role in reducing the stigma around seeking mental health support. Panelists discussed the power of culturally tailored outreach, where communities feel that their specific experiences are seen and heard. Second, we need to adapt our models of care to better meet diverse needs. Now, this means implementing step care models where services are scaled according to level of need, and integrating population-based interventions that focus on promoting mental wellness before problems escalate. It's about being flexible, responsive, and preventive. And third, there's the imperative to support rapid system improvement. This involves building feedback loops where newcomers can directly inform service adaptations, ensuring the system learns and evolves quickly. It's about creating a culture of continuous improvement, where the voice of those we serve are at the center of how we measure success. We also explored the hurdles and drivers of change. On the barrier side, the panelists pointed to a lack of awareness among policymakers about specific needs of newcomer communities, and the difficulty of navigating a fragmented system. Chronic underfunding, workforce shortages, and the stigma around mental health, especially in certain cultures, were also highlighted as significant challenges. But the conversation wasn't all about roadblocks. There are strong facilitators as well. Canada's proactive stance on health and social issues, the resilience of newcomer communities, and the growing recognition of the importance of culturally responsive care. There's also a clear willingness among service providers to learn and adapt, even in the face of limited resources. These strengths can serve as powerful levers for change. Next, we took these insights into a stakeholder dialogue, where we had 16 leaders from across health systems, NGOs, academia, and more. Now, they highlighted 3 key issues. First, the complex needs of newcomer children and youth are creating strains on a mental health system already grappling with inequities, and inconsistent definitions of care. For example, what constitutes adequate mental health support varies widely depending on the region, creating disparities in access and quality. Second, funding gaps and regional disparities are limiting what care models can do. Access to services often depends on where you live. This should not be the case, especially in a country like Canada that prides itself on universal healthcare. But regional differences in funding and availability mean that someone in, let's say, an urban center might receive different levels of care compared to someone in a more rural or remote area. Third, there's a critical need for approaches that are flexible and rights aligned, especially when it comes to building effective partnerships in public health. This is about more than just tweaking existing programs. It's about fundamentally rethinking how services are delivered, coordinated, and evaluated. Stakeholders emphasize the importance of making mental health care part of a broader network of services so that newcomers aren't sent from one department to another, but receive holistic, coordinated care. From this dialogue, we identified key strategies for a comprehensive approach. First, co-designing a framework by involving newcomer youth in the process and developing ethical assessment tools. We need to ensure that the services are not just available, but are shaped by those who use them. Second, adapting models of care to address diverse needs and the unique challenges faced by settlement agencies. It's not enough to have services. They need to be the right services delivered the right way. And third, supporting rapid learning and improvement by building resource capacity with scalable approaches like Project Echo. This model, which links primary care providers with specialists, can be adapted to focus on newcomer mental health, integrating both quantitative and qualitative evidence to drive change. Dedicated funding and ongoing evaluation will be crucial to sustaining these efforts. We also identified barriers and facilitators specific to implementation. On the barrier side, we face a few key challenges. First, government turnover and polarized politics often slow the momentum needed for sustained change. The fragmented nature of decision-making means that siloed thinking is far too common. Policies are made in isolation from one another, making it hard to implement cohesive solutions. There are also too few funding sources that can support promising models of care that focus on holistic health and social supports, which are essential for these newcomer families. Another significant barrier is the limited availability of health and social service professionals who are trained and ready to provide these services. And compounding this issue is the lack of public coverage for key supports, like the translation services that make a real difference in the effectiveness of care. Without these supports, even the best models of care fall short of their potential. On the flip side, facilitators are just as powerful. We have a growing immigration system that recognizes the need for proactive health and social interventions. We have dedicated leaders in the mental health and settlement sectors who are ready to push for innovative, rights-aligned solutions. There's a growing recognition of the importance of addressing social determinants of health and embedding culturally responsiveness into care. With these factors aligned, we have a real opportunity to create sustained change. This isn't just about creating programs, though. It's about fostering an environment where mental health care for newcomers is prioritized, coordinated, and continuously improved. Finally, from the dialogue, the dialogue pointed us to 5 key steps, 5 key next steps. One is creating a community of practice, a national network for resettlement, where resettlement workers can share best practices and resources. 2 is advancing policy changes, looking at legislative and regulatory levers to improve access to care. Now, this includes advocating for mental health to be explicitly considered in immigration and settlement policies. 3 is establishing partnerships for action, collaborating with umbrella organizations to build advocacy efforts and pursue funding. 4, developing standards and guidance, particularly around ethical data practices and mental health support. And 5, explaining the cost of inaction, articulating the opportunity cost of not making these critical improvements. Now, this isn't about making the case that investing in mental health for newcomers isn't just the right thing to do, it's the smart thing to do. And that brings us to the heart of the matter. It's clear we've laid the groundwork for something meaningful here. We've identified challenges, we've drawn on the best available evidence, and we've engaged those directly affected. But this is just the beginning. The conversation doesn't stop here, and the work is far from over. Now, to help us bring this all together and explore the next steps, I'll turn it over to Dr. Amanda Sim, who's been instrumental throughout this process. Amanda.
Great, thank you, Ahmed, for walking us through that. As you saw from the last slide around possible next steps, this isn't something that just one actor, one sector, one stakeholder group can work on to advance efforts around this issue. We require a coordinated, collaborative, and multi-level response, which, as everyone knows, makes things that much more complex. But we need to have those inputs and collaboration happening at different levels and across different sectors, research, academia, settlement, health, and so on, in order to take action. I will, though, mention a few specific ways in which we have tried to operationalize some of the recommendations that we heard from newcomers and immigrants and from service providers and policymakers throughout this process. And also to highlight, some areas in which we have actually seen progress. And one thing that comes to mind in terms of real concrete progress that has occurred in the past year is what we've seen in IRCC's last call for proposals, which I'm sure many of you in this webinar will have participated in. At the end of 2023, IRCC released their national call for proposals, which funds settlement services across the country for the following 5 years. And I believe for the first time, they specifically allocated funding for mental health programming for refugees and immigrants in this call for proposals. And that was a direct result of a lot of advocacy happening at local, regional, and national levels from many of our partners, and I'm sure many of you listening today as well. And I think that's really testament to the fact that if we do generate this evidence, if we are engaging with those decision makers, that those calls for greater investments in mental health support for newcomer children, youth, and families are being heard. So that was extremely promising, and we did collaborate with our local partners here in Hamilton to put together a joint proposal for that IRCC funding. And that proposal really took a lot of the recommendations that we heard through McMaster Health Forum's work, and we incorporated those recommendations and best practices into this collaborative proposal. And the goal of this work is to co-design with refugee and immigrant children, youth, and families a mental health promotion and prevention intervention, one that really centers the voices and needs and preferences of children and families themselves. And one concrete way in which that children's and families' voices would be heard is by making this intervention really family-based. A lot of the mental health services that are provided in this country are very much an individual care model, which does not resonate with a lot of the refugee and immigrant families who come here. And we really heard a lot from parents and caregivers how much their own mental health and well-being affect their children's mental health and well-being. And so the need for a 2-generation family-based approach to mental health care is really important, especially an approach that is prevention focused, that is strengths focused, rather than kind of this individual deficit risk-based model that we often see. Andrea and I have also recently received funding from Public Health Agency of Canada to further this work. And this will be focused on providing culturally tailored parenting and mental health resources, especially for caregivers of younger children, and working with agencies across the mental health and parenting sectors to really develop policies, operational guidance, and resources that are targeted at reducing disparities in access to care among refugee and immigrant populations. And again, we'll be using a lot of the recommendations that have come out of this work to help inform the way we approach those multi-sector collaborations. So those are just some of the ways in which we are trying to operationalize the findings from this study. We know, of course, that there's so much more that needs to be done and that this needs to be a collective effort. And we're really looking forward to hearing from all of you about, what are your thoughts on how we can build on this initiative to advance some of our joint goals? What are ways that, who can we engage in these efforts at different levels to move this forward? And also any questions and suggestions that you have for us in terms of either the findings from this work and ultimately how we can build on it to make a concrete difference in the mental health and well-being of refugee and immigrant children and families in our communities. So once again, thank you to N4 for hosting us, to Kaylin and Ahmed for all of their work, and to everyone who participated in the study, our steering committee, and all of the stakeholders and newcomer participants in the dialogues as well. So thanks very much for the opportunity, and we're really looking forward to a robust discussion.
Yeah, of course. Thank you all for this excellent presentation. And we've got a lot of time here to go through the many questions that our audience has today. So thank you. And let's jump right into it, shall we? First question we have, how are you determining who is at greatest risk? Are you using a standard screening tool like ACEs, PEARLS?
I'm happy to take that. I think that's a really excellent and interesting question. And the question of how we screen and target interventions it's a challenge generally for mental health care in the general population. And I think even more challenging when it comes to ethnocultural groups, refugee immigrant groups, for several reasons. One reason is these standardized tools have often been developed for a very different population, right? They've been developed and tested primarily with a Caucasian, middle class population, and then we adapt them, or sometimes we don't even adapt them. Sometimes we just then apply them to very, very different populations. And so, we have to treat then that data with quite a bit of caution. Do they really assess and reflect the mental health concerns that are experienced by a group that might have very different conceptualizations of mental health challenges, and also where the language used to describe mental health concerns might be very different. And the way that those mental health concerns are manifested, behaviorally, for example, might be really different. So certainly there's a lot of work that could be done around, trying to make those screening tools and assessments more culturally tailored. I would, though, argue for also investing much more in thinking about entry points for identifying children and families who might need more support. And what do I mean by that? I think that could involve really investing much more in interventions, these population level, community-based interventions that really focus more on mental health promotion and prevention, right? Making those supports much more widely available to the community. And through that process, we build trust, which is so key with these populations, where mental health can be very stigmatized and where there are a lot of fears and concerns that disclosing mental health concerns could affect immigration status, and could affect, their reputation, could affect their children's well-being at school and so forth. So building trust is so important, and doing that in a safe way, in a community-based way, allows then children and families to feel more comfortable with then disclosing the need for more intensive support. And it also allows providers then, and I say providers, I mean that in a very broad way, not just mental health service providers, but it could be teachers, settlement workers. It allows those helpers to then be in a better place to identify children and families who might need more support and to really sensitively guide them to where those supports might be. So that would be kind of my take on that question.
Thank you. Thank you for that. One question that came up for me. So with your next steps looking into communities of practice, with finding community practices that may happen to fall into similar areas, how can those silos be broken down so that you can develop collaborative solutions, potentially reducing any sort of, redundant solution development?
I mean, I can jump in quickly, Amanda, just to reflect on the question. And again, I don't live and breathe this space in the same way that Amanda would. So Ahmed and I are often consider ourselves process and methods experts for the evidence support stuff rather than kind of subject matter experts for any of the priority issues we're working through. But I'll start and just say that I think that this happens quite a bit, Andrew, in terms of communities of practice all over the place for different related and complementary purposes, but perhaps there is, some overlap. The Venn diagram, so to speak, may overlap. In the context of this dialogue and what we heard was that there are opportunities to create, and again, I don't know if there's communities that already exist for this, but just sharing experiences, best practices with health and social professionals across the country so that they can work together to kind of crack the nut on some of those really difficult questions. And some of them are popping up in the chat. I see, for example, how do you respond to a child who clearly needs mental health support? Where do they get directed to? And again, that answer would be different depending on which province you're sitting in, and increasingly which region within the province you're sitting in as well. So I think that came out loud and clear, that the community of practice emphasis from dialogue participants was, ideally we would have a network of people who are working with newcomers that are presenting with mental health challenges to work through how they deal with it. And it wouldn't just be health professionals, it would be health and social professionals. So that would include everything like those in the education sector. So I see a couple of questions coming in about settlement workers, all of those types of things. So I'm not sure, again, I don't live and breathe the space, but that was loud and clear. And I'm not sure if there are other networks of professionals that cross-sect health and social and directly address this idea of we need to do better to support learning across professionals, with a specific emphasis on how do we enable those who need mental health supports that are newcomers and children to get, and their families to get the supports that they need. So it's up to, I think others should weigh in if there are networks that make a lot of sense or communities of practice that make sense that this could be added as a potential area of priority. And I'll stop there.
I just want to add, in terms of better supporting frontline workers overall, a clear thing that came out was that Supporting frontline workers means giving them the tools, training, and resources they need to succeed. Another clear thing that came out was the need to invest in professional development, offering mental health supports for the helpers themselves, and creating, like Taylor mentioned, about creating networks where they can share the best practices and lean on each other. And essentially, it's about recognizing that when we support our workers, we're also supporting those they serve.
Thank you. So essentially also just kind of noting as you're building these networks, noting if any others are coming out of the, not out of the woodwork, but like coming out from the discussions as well. Very good. And just to touch back onto it. So if the child needs mental health supports, where should they be directed? To make an appointment for teenagers with mental health specialists usually takes a very long time, and mental health issues need immediate help. Just to touch back on the question that you brought up, Talon.
I think, Amanda, you should feel free to weigh in on this particular, very kind of pragmatic question about actually dealing with a child and their family who needs help. But I do think some of these types of questions are the ones that ideally a community of practice with kind of open channels of communication. I know that they exist in other sectors where you can, pop a question into either a listserv with using really old technology or something more like a social media platform now, where you would have people jumping in and helping answer those types of questions from other professionals serving that population in real time. That could be one potential solution. But Amanda, you might have other things to suggest there.
Sure. Yeah. I mean, I think that the types and levels and availabilities of resources and supports really differs depending on where you are. We talked earlier about long wait times, big gaps in terms of access to care, especially timely care. But as a general answer to that question, although I would encourage you to look into what's locally available in your area, but Kids Help Phone is a good place to start. It's a kind of national helpline where children and youth themselves or someone else could call to talk about their concerns and then get referrals to resources, including mental health providers. But that's one place to start, but certainly if you there would be, in our community in Hamilton, for instance, there are mental health agencies that specifically deliver mental health services for refugee and immigrant children and youth who have experienced trauma and displacement related stress. So that's here in Hamilton. It would really depend in rural areas. I understand that access to services is much more limited, especially services that are tailored for this population.
Yeah, that makes sense. Yes. One of the questions that also came up with respect to connecting to support newcomer health. How would you recommend other sectors connect to support newcomer health, especially childcare, schools, where many families connect early on? What do you see working well? What practices do you see working well as well?
So again, I can jump in very quickly from my experience from other areas of focus more generally. I think, and this came up during the dialogue actually quite a bit too, where policymakers, clinicians, and health and social professionals from across the country suggested, as we all see the value in this. And I think it's about making the case, and Ahmed touched on it in his presentation, that not doing anything really isn't an option when you have an immigration system that is prioritizing, having more people come to the country for a variety of reasons. A lot of them tend to be framed in economic terms, but the knock-on effects for the health and social services are something that folks on this call and at the dialogue are very familiar with. So I think it's about trying to find common ground and framing that enables everyone to see themselves, not just in the way that the problems are framed, but also in the solutions. And I think that, Amanda, your example of the IRCC funding calls with an explicit call out to mental health is showing that some of these barriers are starting to break down a little bit in terms of seeing it as a systemic whole versus a single, but certainly there's a long way to go. I mean, in health alone, just the idea of kind of breaking down silos across sectors within health, let alone across health and social sectors, has been a long time coming, just starting to get under the way in some provinces. So I don't think anyone has the perfect answer. I think that there are efforts, and really it's about the framing, and trying to get everyone on the same page with respect to understanding of the problem, and potential solutions that are open tent versus we'll do this while you do this.
Just to
Yeah.
add,
Oh, go ahead, Ahmed.
okay, I was just going to say, just to add to that, it's also remembering that inclusivity means deliberate outreach and engagement, and that kind of goes beyond like the usual suspect, reaching to all corners of that newcomer community, so large and small, visible and less visible. So we're doing work so people work with the local organizations that already have the trust of these communities, and ensuring that all voices are heard and all needs are considered in planning.
Yeah, I just wanted to kind of echo what Kaylin was saying about silos. And this is something, we've been working really hard at trying to overcome, especially in our local work here in Hamilton. The settlement sector knows all about settlement concerns and has so much knowledge and expertise around culture and intersections between culture and resettlement. The mental health sector obviously has mental health expertise, and then education, childcare, et cetera. But there's so few opportunities for those different sectors to come together. And so in our work here in Hamilton, we've really focused a lot on knowledge sharing and being very deliberate about who we bring together at that table to hear about the findings from this kind of work. And that's been incredibly valuable. We've done this several times now where, folks get to hear about the same issue and the same population of children and families that they all work with in some way, but in very, very different spaces. And for the first time, they're able to kind of hear from each other these different perspectives, but also share similar experiences. And that's been really valuable too, to kind of hear that, if a child is having a mental health issue, it's not just a mental health sector problem. It's a shared problem that we all have to work together to address. And I think there are some promising models. There is a school-based newcomer mental health support intervention, for example, that's been developed and tested in several parts of Ontario. I'm very interested in trying to bring mental health supports more into the community, right, where they're much more accessible. So I'm working primarily with settlement agencies to build that capacity within the settlement sector to provide that kind of first line support to newcomer children and families. So I think there are, promising potential models, but we need so much more investment to really test those, see if they work, and if they work, figure out a way to scale that up.
Excellent all around. Thank you for that. One of the questions that have come up from Lisa Dodara, one of N4's subject matter experts, who is also managing a Swiss program out in rural Alberta. She has a question regarding the family focus model. Essentially, how can we be respectful of cultural beliefs while also protecting clients whose mental health concerns and issues are considered unacceptable in their cultural communities? I know we touched on it briefly a little bit with culture and such. So
it's such an excellent question, and this is a dilemma that I face constantly in my own work. My work here in Canada with newcomers, primarily newcomers who arrived as refugees, is very much informed by my work in low and middle income countries. So prior to joining McMaster and moving to Canada, I worked most of my career in the global south, in many of the countries where refugees originate and then kind of get resettled to Canada. And I continue to do that global work working with communities to understand their needs for support, and then co-designing interventions to address parenting support and mental health needs. And specifically around parenting, this is something that comes up all the time because I work in cultures and communities where physical violence as a form of discipline, for example, is very, very culturally normative. Parents believe it's necessary. They believe it's very acceptable. Everyone does it. And so how do we address this particular behavior that is very culturally normative and acceptable in a way that is going to be sensitive to parents' beliefs, not turn them off, but kind of open that space for them to consider the harmful effects that those kinds of discipline practices might have. And so I think there are parallels, to your excellent question, that I think not engaging parents and caregivers and families isn't the answer, right? Because then those harmful beliefs, practices, and attitudes will just continue. However, that doesn't mean that we just kind of provide tacit approval that those behaviors and beliefs are okay and don't harm our children. But I think the challenge is, how do we engage in a way that is not blaming, is not judgmental, that recognizes where those beliefs come from, and find that entry point and that opening, which usually for me, from what I've seen in my work with families, is usually everyone is committed. They have a joint goal of promoting their child's well-being, right? Most of the time, parents want their child to do well and be well. And so if we work on that premise and we work towards that common objective and try to respectfully and sensitively open up those discussions around how can we support your child together, right? And I find that can be quite effective at helping parents and caregivers to rethink some of these beliefs and practices. But certainly, of course, it's also a case by case basis, right? In certain instances where you're working with a family and you're seeing that there are real harms being perpetrated against that child, or that child is at real risk because of violence in the home, because of discrimination within the home, we have to balance the well-being and protection of the child with efforts to engage families in changing their beliefs and practices.
Of course.
Maybe I'll just add just a little bit of extra, I think, fodder for this conversation. We're not going to get into it today, but just to confirm what Amanda's saying as well, that this came up quite a bit in the citizen panels, and there was another layer of added complexity to the dynamic where in parents, for example, who are newcomers, may over time, as their children become acclimated to their new environment, culture, as we know, children and youth often tend to be quite flexible, and parents, depending on their age, may be a little bit more set in their ways, so to speak. And we heard from several of the folks on the citizen panel that over time there can also be a gulf created between the beliefs and kind of thoughts about mental health more generally among parents and their children that may require services. So it's just another added layer on top of all of this complexity that we heard coming out of the citizen panels. And I thought it was quite interesting to mention that. And then in addition to this, to Amanda's point, I think you were getting at it, if you didn't explicitly mention it, just that in some cultures, mental health isn't even really discussed, whereas here it's, front and center. We have lots of different things that come up where it is a topic of conversation in the health system, in the social system. So that's interesting. And then I'm not going to end on a problem. I'm adding another layer of complexity. I'll end on a solution where our own work is in Ontario with some of the recent transformations of the health system are finding that through Ontario health teams, which are kind of regional integrated networks of care, all the way from primary care ideally to public health, but certainly to long-term and home care, they're identifying priority populations. And so some of these may be newcomers, some of them may be those with mental health conditions, and they're increasingly finding that you need to engage in co-design of models of care. Once you identify priority populations, break them down by kind of needs, and that's one of the ways that you can kind of advance this with cultural sensitivity in mind. So again, it's not the solution that's going to fit everywhere, and certainly it's easy for me to sit here and say, yes, co-design everything and blah blah blah. Where's the money coming from? But I am seeing that in Ontario specifically, that type of approach where, you know, if you're taking a population health management approach, identifying those particular groups and then engaging in active co-design that isn't just a stamp approach and a checklist approach, it's actual co-design of models of care, then you can get further faster. So I thought I'd just add that in.
Yeah, of course. Maintaining both cultural sensitivity and also adding the various different complexities that lie with each specific situation too. One last final question that we have before we wrap things up. This one's related to child and youth mental health services in Ontario fall under the Ministry of Community Social Services. Have there been conversations to include services to refugees or for training their mental health therapists to open these pathways? This one's from Ghislaine Petket.
I don't know the answer to that, Amanda. I'm not sure if you focused on MCSS enough to know if these conversations are happening. Certainly, we talked to folks during the dialogue from this ministry to get their thoughts on it, and you know, some of the things that we presented reflected their comments. So that's as much as I know about this. I'm not sure if there's been any additional discussions, but Amanda, you may.
Yeah, we haven't engaged with this ministry specifically, apart from the work that the Health Forum did through the kind of key informant interviews and so forth. We've been working a lot with Public Health Agency of Canada, as I mentioned before. But I think there are efforts to provide more training and resources, not just to mental health service providers, but providers across different sectors, to increase just knowledge and capacity around understanding the specific mental health needs and concerns of refugee and immigrant populations, including children and youth. For example, at CAMH, there's a immigrant and refugee project where they provide a course that you can take. It's an online course that's targeted at kind of leadership as well as frontline workers. I'm not sure if I have not seen any specific work kind of engaging this particular ministry, but be really something to look into for sure.
Very much. Thank you very much. Very much so. And a lot of discussions going to continue based off of the next steps that you've shown and all the work that's still going on with the McMaster Health Forum and across the country, basically, among many, including yourselves. And once again, thank you so much for this presentation today. As I get the final slides set up, are there any sort of final takeaway messages you would like to give our audience today?
I don't think I just thanks for showing up. There was quite a few people online, so I just appreciate the interest in the topic. And again, thanks to Amanda and Andrea for providing the forum with an opportunity to jump in and help with their work and advance it. Without them, I don't think Amin or I would have felt in our depth remotely. So so thanks, Amanda, and thanks for the invitation.
Yeah, thanks to everyone. And there were so many fantastic questions in the chat, and I'm sorry that we couldn't get to all of them. I could have spent the next hour discussing these really great questions with everyone, but please feel free to reach out to any one of us if you'd like to continue the conversation. I'd love to hear more about the work that each of you is doing around this issue as well.
I just want to add as a takeaway from here is that everyone in this room has a role to play, whether it's advocating for policy change, supporting global organizations, or just simply raising awareness. So I hope you know that you could be an agent of change. As silly as that sounds.
Thank you. Thank you, Amanda. Thank you, Ahmed. Thank you, Talon, all for this wonderful presentation and sharing this valuable information. And we can definitely collate the questions that have come through together that haven't been answered and definitely reach out afterwards to provide that alongside the presentation recording that we will be posting within the next week or so. And with that, thank you very much for taking the time to participate in today's discussion. And thank you, audience attendees, for joining us and engaging with us for today's webinar as well. You're very much welcome to join us again for any of our upcoming events as well. And if you missed any part of today's presentation or would like to watch this session again, we're definitely going to be posting this to the N4 website within the next week. And we want to continue that dialogue. So we will be bringing together these questions and reaching out to Amanda, Ahmed, and Kaylin afterwards as well. So along with that, we've also curated several resources, including the work that the forum has completed, and it will be provided with the webinar as well. And we'll link them when we share the on-demand version of this discussion. So if you haven't yet, audience, please sign up to newcomernavigation.ca for all our resources and learning opportunities. As well, following the session, you will be invited to complete a survey that very much helps us with understanding what new webinar content you're interested in as well. And we kindly ask that you follow that link and complete this brief survey. Along with that, feel free to check out the N4 mobile app available on Apple and Android devices or going through the QR code here. And once again, thank you, Amanda, Ahmed, Kaylin. We hope you can join us again at a future N4 event. We hope that you can stay safe and stay well, everybody. Take care.